We will go ahead and stop the recording about 3/4 of the way through. We're going to go ahead and get started today with a presentation with some of my colleagues regarding the end of the public health emergency, what the BCPH transition and stabilization plan looks like, and what that might mean for all of you in the community. We'll provide a COVID variant update. Then we're going to pivot and provide a brief update on a couple important non-COVID issues that we'd like to have on everyone's radar. And then we'll stop recording and open up the floor to all of you. We'd really love to hear what updates or concerns you might have regarding the end of the public health emergency. And then we're going to wrap things up with a quick poll just so we can get a good pulse on how you all are feeling about the frequency and the format of these calls moving forward. So with that said, I will go ahead and turn it over to my colleagues for the end of the public health emergency presentation.
Hi, good afternoon, everyone. My name is Steffi Goodman, and I'm with the Communicable Disease Emergency Response Team doing data surveillance. And I'm just going to do a little bit of a presentation on what the end of the public health emergency looks like for BCPH. So as we know, the public health emergency is anticipated to end around May 11th. And so we wanted to let you know about our forthcoming transition and stabilization plan, and to find out if this group has any particular needs or concerns with regard to the end of the public health emergency. And so our response to the spread of SARS-CoV-2 will remain a public health priority. Clearly, we are in a better place in our response than we were 3 years ago, and we can finally transition away from the emergency phase and begin the process of stabilization and adopting what we've learned from this experience to strengthen our approaches and ensure response efforts to future communicable disease threats and emergencies. Next slide, please, Stacy. So I wanted to take a quick moment to look back at the 3 phases or plans that were adopted by BCPH over the course of the pandemic as we regularly assess challenges faced by the community and pivoted actions as needed. So we conducted 3 plans. The first one was in the summer of 2021. This was a plan based on the assumption that the pandemic was not over and would likely continue to cycle up and down as new variants continued to emerge, which is exactly what we saw. This plan was written when 70% of our community was vaccinated with at least 1 dose of what was considered at that time to be a highly effective vaccine. And then a year later in 2022, the state guidance changed and the governor issued a roadmap forward. And so BCPH engaged in a series of action planning sessions that helped to realign our agency with those changes. And now, with the end of the public health emergency occurring, we are rolling out what we're calling the Transition and Stabilization Plan that recognizes both the changes in funding that we're experiencing, as well as a move towards working with limited priority populations and specific priority settings. Next slide, please. I wanted to provide a bit of background on the public health emergency, which began in January of 2020. The Public Health Emergency Declaration was intended to provide resources, waivers, and flexibilities to be enacted and carried out by both public health agencies and healthcare systems so that Americans, regardless of socioeconomic status and other factors, had access to care and resources during the pandemic. And with the end of the public health emergency, many of those directives for public health action that were dictated by the state and the U.S. government have ended or will be ending this May. And that's going to transition many things back into our healthcare systems and commercial markets. And our communities have already been impacted and will certainly continue to be impacted as a result of the end of the public health emergency. For example, continuous enrollment for Medicaid ended at the end of March of this year, and it was projected at that time that about half of Medicaid enrollees in Boulder County would likely be ineligible for re-enrollment. So this means that a lot of the eligible beneficiaries would likely need assistance with the re-enrollment process, since that's something that had gone away, and that those who were ineligible actually may need assistance finding alternative resources. And so our plan is to continue to work with local healthcare partners to ensure access to healthcare for those in need. Another example was the Supplemental Nutrition Assistance Program, SNAP benefits, which have also been reduced, and we're working with internal and external partners to assist those with food security and housing stability issues. So in this presentation, we are going to really focus on our role in ensuring community access to things like testing, therapeutics, and vaccinations for community members. And we admit that we don't have all the answers. We're going to continue efforts with partners to promote health equity. Next slide, please. The good news is that on April 18th of 2023, Health and Human Services and the U.S. government announced a program to maintain access to COVID-19 vaccines and therapeutics for uninsured Americans. And this program is going to dedicate over $1 billion and work partnering with pharmacies and public health infrastructure, federally qualified health centers to promote that access to care for uninsured. Next slide, please. And while we can identify some areas where community members may be impacted with the end of the public health emergency, we also acknowledge that questions remain. And so we're going to continue to monitor in the coming months for these somewhat unanticipated impacts to our community. And while the pandemic has not ended, we are going to be transitioning away from an emergency response, which allows our agency to transition into and return to some of our core functions. A large component of the plan will be to communicate changes to our partners and the public and ensure continued access to testing, therapeutics, immunizations, especially to priority populations and in priority settings. Next slide, please. And as we enter this transition phase, our teams are shifting away from what we've called a priority population focus into what we call a priority settings focus. And so I wanted to take a moment to clarify what we mean with respect to our plans moving forward. Next slide, please. Throughout the pandemic, our focus has been to use a public health and health equity lens as we focused on people who were at highest risk for contracting the disease and having the worst health outcomes, such as hospitalizations and deaths. So we referred to them as priority populations, along with people who were living and working in congregate living settings, referred to as priority settings. And with increasing scarcity of resources within our agency, we've narrowed down the priority populations list, and we're focusing on things like making sure that people have free access to vaccines and ongoing communications. And examples of these priority populations are on the left side of the chart that you're looking at. And on the right side of the chart, we define priority settings such as jails, shelters, long-term care facilities, and other congregate living settings, which have substantial impacts on public health. We will continue to investigate outbreaks in and provide support to people living and working in these priority settings as mandated by the state. We're currently awaiting guidance on vaccine availability for these settings. And next slide, please. This slide just illustrates how we made decisions on where to focus our interventions on certain populations in the graph on the left. For example, the orange line shows that vaccine uptake in Hispanic populations lagged behind other populations in Boulder County. And the map on the right shows how we created maps of vaccine rates by zip code, age, and social vulnerability index in order to target interventions among certain populations. And then next slide, please. This slide illustrates the reason why focusing on priority settings is so critical. As you can see in the bar graphs from 2021 and 2022, the outbreaks in these settings increased rapidly during the pandemic, leaving those facilities in dire need of help and support. So particularly within long-term care facilities, correctional centers, shelters, early care and education and school settings and healthcare settings. And we will continue really to focus on those priority settings as we move into the next transition period. Next slide, please, and I will hand this off to you, Colleen. Thank you.
Thanks so much, Steffi. Hi, everyone. My name is Colleen Sinclair. I'm an emergency management planner with Boulder County Public Health. This is my first CIDER meeting, so nice to see you folks, and thank you so much for your time today. So with the background in mind that Steffi talked about, next we'll go over some of our agency strategies that were developed by our teams during this planning process to make adjustments to the changes that we'll see as a result of the end of the federal and state declarations in May. Next slide, please, Stacy. Actually, we can go one more even. First, I'll cover testing and therapeutics for everybody. Thank you. So a little shout out to my colleagues in Boulder County. Well over 500,000 PCR tests were accessed at multiple sites between September of 2020 and January of 2023. I think that's something to be proud of. The end of the public health emergency declaration will impact community members' access to testing with respect to their payer source. Medicare, for example, will cover provider-ordered tests only. Medicaid will be covering testing for their beneficiaries through the end of September of 2024. And private insurance companies will determine the cost of beneficiaries. So we will continue to connect with community partners, making sure they're taking advantage of the remaining supply of the rapid antigen tests at the state. And then we're also looking into some of these increased community access to testing opportunities through organizations like Color Health or LTS, who are agencies contracted through the CDC to provide this testing. And our hopes is to link them with community partners since funding supposedly won't be affected by the end of the public health emergency. We'll also make sure that we're putting out regular communications with the public on how to access tests and to encourage that personal responsibility for testing so that people can follow self-isolation guidelines and prevent further disease spread. So public health will continue to monitor reporting requirements. They're ending at the federal level. They'll remain in the state of Colorado, but that sounds like it'll be reevaluated sometime this summer. And next slide, please, Stacey. So the end of the public health emergency won't directly impact therapeutics since the EUAs for these medications are not ending. And looking forward, there will be some changes coming. So right now, the US government has large stockpiles of oral antivirals, and they're working with stakeholders and federally qualified health centers to ensure equitable access to these therapeutics. They'll remain free until the stockpiles are depleted or until commercialization occurs. We're anticipating seeing that towards the end of 2023. At that point, pharmaceutical companies will be determining pricing. Private insurance companies will determine what that cost sharing looks like for their beneficiaries. Medicare recipients will likely have to pay for a portion of therapeutics. And then Medicaid will reimburse these treatments, but only for FDA approved meds. Right now, that's Veklury. The states will determine if medications that are covered under the EUA will be covered. That's Paxlovid and Lagevrio. Right now in our community, most members are accessing therapeutics through their provider or the telehealth programs that we've seen, or test to treat sites. These might be ending. We just don't have a definitive timeline on those test to treat sites. We'll continue to monitor changes with respect to therapeutic efficacy, any new treatments that come on the market, or changes to the existing treatments. We'll also, big communication plans here. We'll continue to communicate information to community members, encouraging them to have a plan for what to do if they do get sick and provide resources for access to healthcare where needed. We'll continue to review changes in treatment guidelines that come out as well. We'll also be keeping an eye out, monitoring health outcomes, inequities related to therapeutics, and make sure that we're working with the under or uninsured members to assist them with access to care. We'll continue to to work with leadership of healthcare providers like you all and facilities to address the needs of community members. And with that, I'm going to pass it over to Keith to talk about immunizations. Thanks.
Hello, everyone. Thank you. Good afternoon. My name is Keith Rawls. I'm the immunization program coordinator. The immunization program is in a season of transition from COVID response to routine vaccination cadence. The immunization team met to reestablish goals for this transition. These goals include the following. We will reignite the immunization coalition and connect with partners. The immunization team will continue its efforts to cultivate our provider network. We will continue to offer vaccines for low-income children on Medicaid at our 2 Vaccine for Children clinics. Integrated COVID-19 vaccination appointments into our Vaccines for Children clinics. These clinics occur Mondays and Wednesdays. One on the Monday clinic is at the Hub in Longmont, and the Wednesday clinic is at the Sunquist building on Broadway and Iris. The good news is that the Medicaid will allow us to provide these shots without a copay or a cost sharing throughout September 30, 2024. We will execute a fall strategy and offer COVID shots in the community. More will be discussed on the next slide on this. We will develop a fall communications campaign, as Colleen alluded to, as we get back to school. And next slide, please. Over the past few years, the immunization program responded to changing needs. This included ramping up for a mass vaccination campaign, responding to lulls over the summer and peaks in our demand in the winter. We are now in a stable environment for staffing to respond to seasonal approaches to respiratory season. In lieu of the public health emergency declaration ending, we will likely have challenges with getting free vaccine for the broader community, and we'll need to shift our strategy, to our prioritized populations. I'll know more in the summer from CDPHE about the additional vaccine stockpiles. The immunization team successfully pivoted from evening clinics at the Hub to incorporate COVID vaccine appointments into VFC clinics on Mondays and Wednesdays. At this time, we do not plan to run any additional COVID vaccination clinics this fall at the Hub. Instead, we will focus our limited vaccine resources on priority populations. All vaccine clinics will be in outreach settings and will depend on how much free vaccine is available. In summary, the immunization program will continue to provide vaccines to uninsured and underinsured populations of Boulder County and will be agile in this space going forward. The next person, I believe, is Stacy. Thank you, folks.
Hi, everyone. I'm going to keep my camera off just because it sometimes messes with my sharing of the slides. So I am with the Communicable Disease Program. Just going to mention some things about epidemiology, infection prevention, and surveillance. So our EPI approach has shifted over time from strict guidance to protect the healthcare system early in the pandemic. Then gradually, we were able to shift those EPI response strategies due to increased community immunity resulting from vaccines, widespread disease, and along with access to therapeutics. Focusing on priority populations has been crucial, and it's helped us with these relationships with our key partners in priority sectors that have helped us be successful with many changes in the pandemic. This fall or this late summer, we will be reducing our ELC-funded staff resources from 20 staff to 6 FTEs for all COVID-related epidemiology, infection prevention, surveillance, resource navigation, and call center needs. And remaining staff will be focusing on ensuring stabilization of key activities over the coming months. This slide illustrates the ongoing COVID response needs that will continue for our team. In 2022, BCPH investigated a total of 403 outbreaks at a rate of 122 outbreaks per 100,000 population. This reflects an increase over the pre-pandemic 5-year average of 19.2 per year by approximately 2,000%. While most of these outbreaks are from COVID, and they accounted for 80% of them, there was also an uptick in non-COVID respiratory outbreaks and enteric outbreaks in 2022 compared to other years. To keep up with the increased workload, we anticipate staffing resource needs will be ongoing after the response-related funding dries up. So our goal is ongoing adaptive operational model. And what that means is our community has benefited from that strong collaboration with various partners such as CIDER, which engages our healthcare IPs, our IED docs, our long-term care facilities, and congregate settings such as the jail. Public health needs to be prepared for future threats, such as how climate change and globalization will likely accelerate communicable disease burden and emerging threats. Our ultimate goal is to ensure adequate staffing resources for ongoing adaptive operational models that takes into account the complex landscape that we have navigated and continue to do so. And I want to thank you for your time today with this. And is there any questions? And I cannot see the chat, but you're welcome to put them in the chat or go ahead and unmute yourself and we'll address your questions here.
We don't have anything in the chat yet, Stacy.
Okay.
Or nothing that's been unaddressed.
Okay. Well, going forward, if you do have something you think of, go ahead and put it in the chat. We can catch it later, but I'm going to go ahead and move towards COVID updates with Steffi Goodman again. Steffi, are you there?
I think you're muted, Steffi.
Yeah, thank you. Sorry. Thank you, everyone. Just wanted to give a couple of quick COVID updates. So next slide, please, Stacy. The green map on the left, as you're probably familiar with, shows the community levels and shows that about 98% of counties in the United States are in low community levels. And again, this is based on a 7-day cumulative case count per 100,000, also the 7-day total new hospital admissions per 100,000, and thirdly, the percent of inpatient beds for a 7-day average. So I just wanted to give the quick caveat that case numbers are vastly underreported, and we'll look at that in the next slide. But hospital admissions are also often underreported since a rapid antigen test or home test is often accepted, and the cases are then counted as suspect cases and not laboratory confirmed cases. And the map on the right shows the transmission levels map that's produced by the CDC. And this is the metric that's used by healthcare facilities to determine infection control interventions. Transmission levels were based on 7-day cumulative case count per 100,000 and percent positivity. And so importantly, with the end of the public health emergency, things are changing. For example, the reporting of negative test results is going away. And with the huge decrease in PCR testing, percent positivity is essentially no longer going to be reported, which then affects the metric that healthcare facilities are using to determine infection control interventions. So I just wanted to let you know that the CDC is currently reevaluating how they're going to revise the reporting of transmission levels for healthcare facility guidance. So more to come in that space. Next slide, please. And this slide just demonstrates how wastewater surveillance actually shows that how underreported COVID-19 cases are since the spring of 2022, when home testing became more available and actually free community test sites were dropped in many locations. The comparison graphs between wastewater and case numbers are similar in Boulder and Longmont utilities, which are the Boulder utilities on the left. The Longmont utilities is on the upper right graph, but it's also very consistent with the bottom right graph, which is actually from BioBot, which is the company that is contracted with CDC to do the wastewater analysis for the United States. And this is showing a very similar graph of wastewater surveillance and case comparisons across the United States. I think it's a fairly dramatic illustration of what's happening with case reporting. Next slide, please. The next couple slides just look at our variant update. I'm not sure how much you follow the Nowcast report, which estimates the current variant in the United States, XBB.1.5, has been the most prevalent subvariant for quite some time, really, since January of 2023. It is still the most prevalent at about 68% of cases, but is finally decreasing. And in its place, we're seeing on the bottom sort of right corner here, the purple is XBB.1.6, the XBB.1.16, sorry. And that is now the second most prevalent variant in the United States at almost 12%. This is a variant that has been surging in India. Early data suggests higher transmissibility compared to XBB.1.5, similar immune escape, and nothing that's showing more severe disease. They do suggest an additional new symptom of some conjunctivitis. But we also note that XBB.1.9.1 and .2 are also increasing in the United States. We don't have much data on what to expect with these variants. And next slide, please. And this slide just shows the Nowcast estimates for variants by region in the United States, and Colorado is in region 8. We can see that XBB.1.5 is still the most prevalent variant. It is decreasing on all the different regions. XBB.1.16 is growing in all regions, and XBB.1.9.1 and 2 are about 16% in region 8. That includes Colorado. So that's all I have for COVID updates, and I'll pass it to you, Elena, for non-COVID updates. Thank you.
Thanks, Steffi. I think I forgot to introduce myself earlier, actually, but my name is Elena Younger, and I'm the interim regional epidemiologist. And thanks to my colleagues for all those super important COVID updates. We're now going to actually pivot and give a couple brief updates on some non-COVID issues that we think should be on everyone's radar. Okay, so the first one pertains to a health alert that came through the Health Alert Network on April 18th regarding opioid overdoses involving xylazine. Cases of overdoses involving a new illicit street drug that mixes opioids, typically fentanyl, with xylazine, which is a veterinary tranquilizer, are being reported in Colorado. This drug combination is commonly referred to as tranq. In the last 14 months, there have been 4 drug overdose deaths in the Denver metro area that involve xylazine in some form. And we've recently been informed that xylazine has been detected in Boulder County's illicit drug supply. The DEA lab system reports that in 2022, approximately 23% of fentanyl powder and 7% of fentanyl pills contain xylazine. Common symptoms of xylazine-laced drug overdoses include unresponsiveness, decreased responsiveness, hypotension, bradycardia, meiosis, and reduced or slow breathing. Because xylazine, which is a non-opioid, is often combined with an opioid, naloxone may not be effective in treatment of a tranq overdose. Nonetheless, healthcare providers are still encouraged to administer a naloxone and manage the patient's symptoms supportively with a heightened awareness and management of the patient's airway and breathing. Additionally, a careful skin exam should be performed in intravenous drug users, as xylazine has been known to cause severe wounds and necrosis that can lead to amputation. Wounds can also occur in other locations, even when xylazine is smoked or snorted. And down here at the bottom, we've included an important resource for all of you that hopefully you're already well familiar with. But the Rocky Mountain Poison Center can provide consultations 24/7 at the phone number listed below on any case of suspected opioid-related overdose with xylazine or for more information about this combination. Next, there was a health advisory that was released on April 10th regarding an update for the ongoing outbreaks of Marburg virus disease in Equatorial Guinea and Tanzania. Marburg virus disease is a rare but highly fatal viral hemorrhagic fever caused by two zoonotic viruses, the Marburg virus and the Robin virus. And these are both filoviruses in the same family as Ebola virus. MVD is transmitted via direct contact with blood and other bodily fluids of infected people and animals, or indirect contact with contaminated surfaces and materials such as clothing, bedding, and medical equipment. It's important to note that Marburg virus, like Ebola, is not an airborne disease, there is no evidence that MVD is spread by coughing or sneezing. There is no approved vaccine, although a vaccine is currently in development. Symptoms of Marburg virus disease appear 2 to 21 days after exposure, typically with rapid onset of fever, chills, headache, and myalgia. Around the 5th day after symptom onset, a maculopapular rash may appear, and this might be most prominent on the trunk. Additional symptoms may include nausea, vomiting, chest pain, sore throat, abdominal pain, and diarrhea. Symptoms typically become increasingly severe and can include jaundice, inflammation of the pancreas, severe weight loss, delirium, shock, liver failure, massive hemorrhaging, and multi-organ dysfunction. Again, there is typically a high case fatality rate with Marburg virus disease, ranging between 23 to 90%. On average, it's about 50%, and it does depend on the virus strain and case management, which is typically supportive. So there are two unrelated outbreaks that are ongoing of Marburg virus disease in Equatorial Guinea and Tanzania. Again, these are unrelated outbreaks with different strains of the virus, and they are at this point fully contained to both of those regions. So again, to reiterate, no confirmed cases of MVD have been reported in the United States or outside of regions. However, there is always the risk for potentially imported cases. So again, the risk for the US is low, but it's important to keep on your radar, particularly if you have patients presenting with recent travel history to Equatorial Guinea or Tanzania. The CDC is currently sending mobile text messages to travelers who have been in Equatorial Guinea or Tanzania and have now arrived back in the United States. The message explains what symptoms they should watch for and to contact their local health department or their healthcare provider if they are to develop symptoms of illness within 21 days. Entry screening and risk assessments are not currently being performed. And while BCPH is being notified of travelers returning from these regions, we are not performing any active monitoring because it is not currently recommended by the CDC. If that changes, then of course our approach would change accordingly. Recent presence in Equatorial Guinea or Tanzania should not be a reason to defer any routine laboratory testing or other routine care. And again, really important to note that just like Ebola virus, Marburg virus disease, or individuals that are infected with Marburg virus are not contagious before the symptoms appear. They are only contagious once symptoms do appear. So there is no role for pre-symptomatic transition or transmission. If MVD is suspected among any of your patients, you should all follow the same protocols more or less than what we do for Ebola virus disease, primarily identify, isolate, and inform. So if someone is presenting to an ED or another healthcare setting, relevant exposure history should be taken, including criteria about whether the patient has traveled internationally, particularly to an area with an active outbreak, or if they've had any direct contact with any individuals with MVD or other viral hemorrhagic fevers in the last 21 days. If patients do meet these exposure criteria, they should be further evaluated to see for the presence of any symptoms compatible with Marburg virus disease. If they do have symptoms or signs compatible with MVD, they should be isolated in a private room, and personnel should follow the same infection prevention and control measures as recommended for Ebola disease. And of course, please do make sure that if you have any individuals with the consistent exposure history and consistent signs or symptoms, to go ahead and call CDPHE immediately at either phone number that is listed, and CDPHE will help determine if this individual should be considered a suspect case and if additional testing or additional precautions need to be employed. We do have some updated resources to share with you all. I know that seeing the links doesn't, in the presentation doesn't allow you to click on them or anything. So we'll be sure to send out all of these links and resources along with the recording after this meeting. But CDPHE has updated their viral hemorrhagic fever webpage, and it now includes a great toolkit for hospitals on what to do if you suspect a patient has Ebola disease or Marburg virus disease. And of course, if you are hearing both of these updates for the very first time, that means that you're probably not registered to receive health advisories and health alerts through the Health Alert Network. You can register for any alerts that originate at the state level by following this link that's provided under the last section. And just be aware that signing up at that link does not enroll you to any HANs that originate with Boulder County Public Health. But we are doing an update project. So we are planning on reaching out to pretty much every single facility in the county within the next month to get updated contact information so we can also enroll you for local HANs as well. I'm going to go ahead and stop recording, and then we're going to go ahead